Professor Brew, can you hear me?
Yes, I can.
Okay. So we're all together here. Stephen is here as well. So you can start wherever you like.
Okay, we better get going. All right, thank you very much to the organisers for inviting me to speak. I hope you find this informative. So my task is to run through long COVID in relation to cognitive impairment. So the overview, I'll talk about a potential theoretical pathogenetic framework, because just take a step back to get an idea of what potentially is going on. Then I'll go through existing studies on cognitive impairment. Then the thorny issue of whether there is truly direct brain infection from COVID. Then I'll focus on the coronary pathway because that's the link that we've found. I'll give some background into the existing studies that substantiate this as being important, and then I'll go through the detail of the ADAPT study. So just taking a step back to have a very general idea of what could be going on in terms of cognitive impairment in the context of long COVID. On the one hand, it could be a single hit from the pathogen, that is COVID, or it can be some sort of host response with either no recovery, a stalled recovery, or stunted recovery, or clearly a stalled and stunted recovery, or some mix of that nature. Alternatively, it could be recurrent hits. In other words, you get infected with COVID and there are blips of further infection along the way explaining long COVID, or there's some sort of recurrent host response sort of hitting you from time to time. And again, the same sort of outcomes, either no recovery, stalled recovery, or stunted, or some combination. That's a very general pathogenic framework, but I think that's important because I think most people have this concept that long COVID, at least in relation to cognitive impairment, is, well, I guess it's dichotomized. Some people think it's just it's a hit and you're just slowly recovering. Other people think it's an ongoing process. But I think it's much more complicated than that if you think about it in just very general terms. So what are the existing studies on cognitive impairment in long COVID? Well, it's a bit of a mess, to be frank. Lots of studies have understandably been done in a rushed way, and I don't think has been appropriate thought given to what should be studied and how it should be studied. So the acute disease is clearly heterogeneous, and it's even more heterogeneous when you get out into long COVID. The severe cases that require hospitalisation are really a cohort of patients that are exposed to a number of hits, if you like, hypoxia, stroke, possibly some autoimmune phenomena and inflammatory response with the cytokine storm. Whereas the mild to moderate cases, those who are not hospitalised, that really provides a different cohort of patients who give you, and that gives you a window into understanding what potentially the direct mechanisms are. And the other general issue is that a lot of studies have really not paid appropriate attention to comorbidities, have lumped them together, if they've identified them at all, and they've not tried to quantify them in any sort of way, including illness-associated psychological distress. And then the assessment of cognition, understandably, in some studies has been very haphazard because of limitations of the patient clientele and the milieu in which the assessments are being conducted. Nonetheless, very few have adopted any sort of objective assessment. So there's been a lot of subjective reporting, which has got into reasonable sort of journals, surprisingly, but it's really not on to get a handle on the disease, on this new concept of a disease, just from telephone interviews. And flip side of that is that the batteries that are used, even when they're not just telephone interviews, have been very limited, MOCA or the mini-mental state, which have some utility, but again are not good for really accurately defining this entity. And then there haven't been appropriate corrections for normative demographic effects and very few longitudinal designs, and just about none have used any sort of methodology to correct for practice effect. So clearly, if you're using the same instrument to assess cognition, you will have a practice effect and you will miss true deterioration and will be clouded by just improvement from practice. And then the other big issue is, of course, sample size adequacy. So just to run through this, the 22 studies that have been published looking at PASC or long COVID. And I won't go through each of these. I'll just serve to highlight the ones that have some aspects that are useful, but the message is no study thus far has really ticked all the boxes. So you can see one study here from Italy was longitudinal. That's good, but then they used the MOCA. One study here from the US with Jim Becker was longitudinal, or at least it evaluated patients at 7.6 months, but it was in fact cross-sectional. And then another study from Ecuador was longitudinal, but they used only fairly straightforward instruments such as the MOCA. Again, another study from US, longitudinal, but again, the MOCA was used. Then we have a study from Sweden, which used the R-bands. That's good to an extent, but it was cross-sectional. And then a Chinese study was longitudinal, but they had telephone interviews for cognitive status. Another study from Italy, reasonable cohort of patients, but was cross-sectional. Another study from Italy, longitudinal, but very basic assessment tools, same from a Danish study. And then a UK study, praiseworthy in that it was longitudinal, but a mix of patients, and they only used the MOCA. And then another Chinese study, cross-sectional. They used some good tools, but it was only 2 to 3 weeks after infection. So unfortunately, 0 out of 22 studies were longitudinal, focusing on mild to moderate COVID with objective assessment tools. So we really don't, until I think the ADAPT study, which I'll hopefully convince you of, have a good study precisely defining what this entity is. Now, what about direct brain infection? Because there are some studies, there's a concept out there that this is a consequence, that cognitive impairment from long COVID is a consequence of direct brain infection. Well, the evidence would be not really that much in favour of that as a possibility at all. So again, 22 autopsy studies, and they're the usual caveats with these autopsy studies. They're looking at clearly severely affected patients who've died. But nonetheless, even in that cohort of severely affected patients, only 6 studies found evidence for the virus. And that has to be tempered against sampling error, small numbers, and the big question, which always plagues these studies, is to what extent are you truly seeing brain infection versus contamination from blood? So I think the bottom line for direct brain infection is it may happen in some cases, but it's the minority, not the majority. The overwhelming theme in the most recent autopsy studies is that virus is not there to any extent, and second, that this is a macrophage-mediated disorder. Now, that's the autopsy study results. What about CSF? This is a study from Magnus Gislin's group in Gothenburg in Sweden, and it shows you that you can find not necessarily productive virus, that is replicating virus, but you can certainly find evidence of nucleocapsid, in other words, the viral components in the CSF, which correlates with inflammatory markers like neopterin, interferon gamma, and so forth. So bits of virus are there, but not whole virus. And then there's this small study, but quite intriguing and potentially very informative from San Francisco, from Michael Wilson's group. And they had they took the approach of looking at the blood from patients with neuropsychiatric syndromes, as they put it, with and without, and found looking at exosomes. So these are vesicles that you can derive from the blood. They're very small, and you can then unpack the contents of the vesicle and work out what they contain. So what did they find? They found that these vesicles they had hallmarks that said they were coming from the brain, so not from other parts of the body, and the contents of the vesicles were related to, again, bits of virus, so the nucleocapsid and the spike protein, and there was more of either of those or both components correlating with neurological complaints. They didn't go into depth what those complaints were, and they didn't really exhaustively test for cognitive impairment. But the bottom line is these bits of virus may be much more important than we think. They're certainly present, as I said, in CSF and in these vesicles that you can derive from the blood. They may be potentially immunogenic, if not neurotoxic. So that's the evidence for direct brain infection, which, as I said, is very limited, but indirect mechanisms via fragments seem to have more of seem to have more traction. Now, why did we look at the kynurenine pathway? Well, it's a long-standing interest of my group, and I'll give you some solid background to say that to be confident that there is a relationship from published literature. But just to step back, the kynurenine pathway is a tryptophan degradation pathway. So the tryptophan is an essential amino acid. Now, on the one hand, it'll produce, when it's really activated, switched on, some neurotoxic products that'll kill nerve cells or at least injure them, and it will lead to energy depletion because it's of mitochondrial toxicity. But it also does have a benefit, at least in the short term, not in the long term. And the benefit in the short term is that it tries to down-regulate your immune system, tries to induce tolerance, and it has a degree of antiviral activity. So it does have a purpose, which sort of makes sense. The toxin itself, this quinolinic acid, is a relatively weak toxin. Again, that sort of makes sense. If you're switching on the pathway to try and quell your immune system after it thinks that it's dealt with whatever the insult is. This is just another representation of quinolinic acid, the toxin that I mentioned, because it has a multiplicity of effects. It'll damage the blood-brain barrier in the long term. It'll cause nerve cell damage, and it'll cause mitochondrial damage, as well as to damage of the supporting cells, the glial cells in the brain. So that's all well and good, but what is the actual evidence to say that this pathway is important in long COVID, or at least in COVID anyway? Well, there are some data from mid-2020 from in Journal Clinical Investigation, and these are pretty convincing data. So it was an agnostic approach, looking just to see what fell out when you looked at the metabolic profile of patients with COVID at various time points. Now, the numbers are relatively small, but nonetheless, the theme is pretty convincing. And that is products of the kynurenine pathway, particularly kynurenine, stand out. And then you go for a more refined analysis, and you can see that these products are all components at various stages of the kynurenine pathway. So it's not the only thing that's upregulated from a metabolomic approach, but it is of relevance from a brain perspective. And so it gives credence to the kynurenine pathway being important in COVID and potentially in long COVID. This is just another set of data from the same publication reinforcing that there is a real signal for upregulation of the kynurenine pathway, particularly this middle product, the kynurenine. So that's one study. What about it? Are there any other studies? There are quite a lot, but I chose these two because they were perhaps the most convincing. And the second study is in scientific reports. And you can see, again, this is looking at urine metabolomic studies of patients. And again, a reasonable number, not a high number, but a reasonable number, both critical and non-critical patients. And the big hits are all related to kynurenine pathway products. So it's pretty convincing. These studies were done with no preconceived notion of what they would find, and it fell out that the kynurenine pathway metabolites were detected significantly. So I think there's a reasonable body of evidence to say that the kynurenine pathway should be activated and is activated. Now let's move to the ADAPT study. Now it's very important that I think everyone understands that this is a team effort. Lots of people put a lot of work into this, and I'm just the backseat driver. Lucette, I particularly want to mention, was extremely helpful, and Gilles in terms of the kynurenine pathway analyses. So what did we find? First up, the demographics. When we had 128 patients, we were able to follow the vast majority of those through for 12 months. There are other data points beyond that are still to be analysed. Most of them were in their late 40s. There's a reasonable split with sex, and they're reasonably educated, and with a reasonable number of medical comorbidities. We employed the Cogstate, which is a standardised tool that has a computerised battery of tests. It's been used in many disease states. It's got a long history of utility and validity. And we also use the NIH olfaction detection kit from NIH. So we found at 2 months there was evidence of mild cognitive deficit. Then at 4 months, 21.5 and 25.7 at 12 months. There is a trend towards some worsening of cognition with time, which was a surprising result, but it has to be taken a little cautiously because we lost some patients. We lost about 20 patients at 12-month follow-up. Then the next question is, because a lot of people say, well, sure, we're all forgetful from time to time. Was it just a little bit of cognitive difficulty, and what's the big fuss? Well, the big fuss is it does have functional impact. We used a 6-point scale and asked for responses to these questions. Fully recovered versus confident of returning to pre-COVID work, to usual activities of daily living, normal exercise level, and then repeated those. And you can see that whilst the majority of patients certainly did do well, a sizable minority did not do well. And so it has functional impact, the cognitive impairment. Now, not only did we see this reasonable frequency rate for cognitive deficits, and remember, we corrected for practice effects. This is not a practice artifact. But we also found that even patients who were unimpaired became, they did slip and became not necessarily cognitively impaired by our definition, but they did not stabilise, and some worsened. And the next important finding was we tried to look for what the relationship to the cognitive impairment was. So is it just an artifact or a consequence, if you like, of comorbidities? No, it's not. Is it a consequence of the worried well who had some sort of psychiatric disturbance, psychological disturbance beforehand, or illness behaviour related psychological worry? No. Was it related to the severity of the disease, remembering that the vast majority of the patients had mild and moderate disease? No. We had a few patients who had severe disease and it still didn't pan out. Was there a relationship between lung capacity? So reasoning perhaps, well, these patients didn't have overt significant hypoxia because they weren't hospitalised, but maybe they had just mild chronic hypoxia? No. There was a relationship to anosmia at 2 months, but it disappeared after that. What we did find was this relationship to the kynurenine pathway metabolites, and the most significant was was related to quinolinic acid. So you can see that there was a very significant relationship between those who had cognitive impairment and those who weren't impaired. And that's for each of the components of the kynurenine pathway. There's this thing called the kynurenine-tryptophan ratio, which some places around the world use as well. So how did that pan out over time? You can see that the components of the kynurenine pathway did vary. So some didn't change. The 3-hydroxyanthrenic acid, for example, didn't change that much, although it was significant. There was a drop in the kynurenine pathway, in kynurenine concentrations, which was very significant. But most intriguing was this relationship to quinolinic acid, which was very significant. And you can see this quadratic relationship, so that it slowly declined as we get out to 12 months and in some cases beyond. I'll emphasize that because I think that has potential pathogenetic and treatment-related importance. And then anthrenic acid slowly declined, which is probably good. We compared it to a number of different controls, healthy controls, some other controls, and the message was the same. Elevated quin, which was significant, and some of the other metabolites as well. In more detail, if you look at that cut point of 605 nanomolar, so cognitively impaired, 73% had that elevated quin. 63% if you use the ratio. How come 35% had elevated quin and they were not impaired? Well, I think that we were looking at the blood. We were not looking at the spinal fluid. And I think you have to remember that this pathway is represented throughout the body in various cells. And there is reason to think that maybe it's contributing to some of the other manifestations of so-called long COVID. Just to drive home the point that of the patients who were cognitively impaired at this time point, that's a split. And then we looked more at the pattern according to what as a standard cutoff for quin by months post-diagnosis. And you can see there was a peak around 4 to 8 months, and then by 12 months, about 20% still had elevated levels, reflecting that quadratic relationship that I showed you before, the same sort of relationship with the kynurenine-tryptophan ratio. So then returning to that very general approach that pathogenetic framework that I introduced at the beginning, what can we say? How can the data really help us? Well, I think we can say once you've had COVID, it's not as though you're having repeated blips of infection. So I think that's out. And I think we can say that because of the quadratic quin relationship and the relationship to quinolinic acid and cognitive impairment, that there may well be reason to think that there'll be some recovery, but it will be delayed. Because remember, the quin really didn't start to really significantly drop till about 12 months, but there were some patients who were still elevated. But it looked as though if we keep on studying them, that they will eventually normalise. But it'll be out beyond 12 months, possibly even to 2 years. So it raises a point, I think, that we're not seeing recurrent hits from the pathogen, we're seeing sustained hits from the host, and that's by virtue of the kynurenine pathway. Now, I have to emphasise that we looked exhaustively for other relationships. We thought that there should be a relationship between some of the cytokines and cognitive impairment, and there was not. We certainly found IL-6 was elevated, but IL-6 did not correlate with cognitive impairment. We found interferon beta and interferon lambda were also elevated, but they did not correlate with cognitive impairment. The only thing that correlated was quinolinic acid and some of the other kynurenine pathway metabolites. So I think we can say that can advance a hypothetical model. That is, viral fragments, at least in some patients, for whatever reason, perhaps delayed clearance, inadequate clearance, switches on the pathway, and that leads to cognitive impairment, and or in some patients, the pathway is dysregulated. Remember right at the beginning I said the purpose, at least genealogically speaking, for the pathway is to really dial down your immune response. After you've mounted an immune response, you need some way to down-regulate it and eventually turn it off. Well, for some reason, the turn-off switch isn't, or the dial is not working, and that's leading to a production of toxins, neurotoxins via the kynurenine pathway. Now, an intriguing model of inflammation in general has been put forward in the last few years, which I think is starting to become accepted in the field, and that is, again, at a very helicopter view of inflammation, you have some sort of insult that causes infiltration by immune cells, edema, a resolution phase, and now there's this third phase called post-resolution, which is contingent on a number of cells, particularly Tregs and macrophage reprogramming. And I've put forward the idea that maybe long COVID is some sort of disruption in this transition from resolution to post-resolution phase. That needs to be worked on, but I think it's an interesting possibility with spillover to pathogeneses of other conditions. So what does all that mean in terms of treatment? Well, given that we've got a target and we've got a biomarker, we can look at various drugs that have been developed for other conditions that modulate the KP, either attacking the first enzyme, IDO, or KMO, the middle enzyme, or directly against QIN. But it would have to be modulation, not inhibition, because you want to dial down, you don't want to switch off. And another intriguing possibility would be cytokine modulation, particularly looking at IL-6. We did find IL-6 was significantly elevated, not related to cognitive impairment, however. Nonetheless, IL-6 is a well-known upregulator of the kynurenine pathway. So if we could somehow maybe dial that down with existing IL-6 monoclonals, that may have some utility. Then there's a whole new class of drugs called resolvins that are being developed that will attack that third phase of inflammation. So, as I said, this is work not by one person, it's work by a team. And the ADAPT team, each member really deserves credit, but particularly Lucette Suzuki, from the cognitive aspect of things, really drove it at an operational level quite extraordinarily. And then, of course, Gail Matthews and Dave Darley were instrumental, as well as Greg Dorr and Anthony Byrne. But the real, this study would not be studied, of course, without the patients of the patients being poked and prodded, but they who gave their time. And I think for a fruitful outcome, because we, as I said, now have a target and a biomarker. Gilles Grenouin and his team for the KP analysis. And these things require money, unfortunately, and a lot of gratitude goes to the Curran Foundation and Spencer's Clinic. Thank you. I'll stop sharing.
Please thank Professor Brew. And we will hand over to Professor Foe. Okay, test.
Hi, thanks for coming. Bruce's research is probably the first bit of research to give us some form of a target or an understanding of what happens to people's thinking during COVID. And I think we're at the very beginning of it. So I'm just the clinician. So we use all the research people like Bruce do to try and apply it to people. And I'm just going to give you a quick rundown on long COVID and its clinic and why people, and our clinic, and why people with traumatic brain injury might be a little bit more sensitive to some of the impacts of long COVID. So I just press this down, right? No, it's not happening. Press it up. No. Press it along. No. Press it the other way. No. I'll just click the thing, maybe. Here we go. Yeah. Rightio. So I just want to say that I'm a public servant and a conjoint academic, and I don't have any conflicts of interest to declare. So the rehabilitation community practice in New South Wales wrote an article fairly early on in the pandemic, in about June of 20, saying, listen, there's going to be problems, and not just at the beginning, there's going to be problems at the end. And if you don't start thinking about the end now, we're going to have major difficulties. Because what we identified was there's no uniformity of response in New South Wales with respect to rehabilitation. We also found that a lot of staff and members of the public were pretty flipped out about COVID. There was a lot of panic, and I've got to say there's nothing that sharpens the mind like panic. And a lot of people who were in the staff suddenly did things that they'd never done before, like talk to each other. And so there was quite a lot of goodwill. There was also in Victoria, I don't know if you know, I don't know if there are people here from Victoria, but in Victoria the way the health system's divided is there's clusters of hospital who do their own thing. So when COVID came, each different cluster of hospital did their completely own thing, which meant that instead of having a centralised sort of public health service, all these clinicians in Victoria who were in charge of rehab units were told to be the public health officer without much training. So it was all over the shop in Victoria, and they had quite a few lockdowns. The other thing to be aware of about the health system is that it's a mixed public-private system, and it's a mixed federal and state system. And that was a major problem because aged care facilities and private hospitals are run federally by private institutions who don't like sharing. So they didn't talk to each other, and there was heaps of different rules about going to visit people in aged care. But, as I was saying, people got very frightened. There was unprecedented cooperation between health silos. And it's amazing to tell you that there are many people who didn't know what rehabilitation was until COVID. There were many of our colleagues in ICU and ED who'd never talked to a rehab physician, who had no idea about the chronic end. So it was a pretty good opportunity, and we took it. And I'll press here. So what we said was that there were going to be a few waves. Right? We said there was going to be the first wave, which was people getting sick. Then we said there was going to be a second wave, which was that there were going to be people not going to hospital after head injuries or strokes or hypoxia because they're too frightened to go to hospital because you can get COVID in hospital. So then what happened was all these people presented with stroke really late, very sick. And we were saying, hey, you've got to cope with this because people are going to come in very sick, and our rehab units are going to be full of these people because their mild disease wouldn't be treated. And then we said, look, the other thing that was going to happen down the track is that all these people who come into outpatients for their, falls prevention and strengthening programs and walking programs, they're not going to come in because the outpatients are all shut. And after about 3 months, they're going to become really deconditioned and they're going to fall over and break their hips. And that's what we saw. And then, of course, we said, look, if you've got a mental health problem, you're going to be in terrible trouble for a very long time. So we warned in our article, this is going to happen. We didn't even think about long COVID, but that's clearly another manifestation of it. So the long COVID definition by the WHO, and its fancy title is the post-acute sequelae of COVID. And the reason they use that title is because a lot of people their symptoms don't go. So they get COVID, and then they've got fatigue, and then they still got fatigue at 8 weeks, and they still got fatigue at 10 weeks. But it's only long COVID if you got fatigue after 12 weeks. You've got to have the symptom for 3 months. So many of the hospitals who had a lot of people who were suffering with COVID set up these post-acute sequelae of COVID clinics because they knew when they discharged people they were still not right. So who's at risk? This changes depending on what country you're in, but women are more at risk than men. Middle-aged people are a bit more at risk. People with 2 or more comorbidities, and TBI, that's a comorbidity. A stroke, that's a comorbidity. Acquired brain injury, that's a comorbidity. dementia, that's a comorbidity. And then if you had on top of that a bit of hypertension or diabetes or something, you got 2. So if you've got a traumatic brain injury, unless you're super duper healthy and really young, you're likely to be a little bit more likely to get long COVID. There's some blood tests that we know that show if you have a persistently high inflammatory response, and also we know if your clotting ability in the blood is still high after a long period, you're at higher risk. And then, of course, if you went to hospital and you went to ICU and you needed mechanical ventilation, or you had an acute respiratory distress syndrome, you're more likely. Now, one of the reasons is you're probably more likely to not get enough oxygen. So if you already have some brain damage, then you're going to get a little bit more brain damage from hypoxia if you go to ICU or have to have high flow oxygen. And then we found that people who had severe disease were more likely to get long COVID, but it also happens in mild disease, as Bruce showed you. And what we found as well is people in lower socioeconomic groups are more likely to get long COVID because poverty and health are inextricably linked, and so they're more likely to be unwell. So what does it look like? Well, this is interesting because it's all different in different countries. So in post-hospitalised patients in the UK, 30% felt recovered at 3 months, so 70% didn't recover. 20% reckon that they had a new disability that they never had before, and 19% in the UK had to change jobs, probably because of cognitive impairment. Maybe they had manual jobs and they had to change it because of physical reasons. There were 4 major sort of phenotypes of the way it looks. There were mild people mostly. There were moderate people, people who had a bit more than mild, they might have got a lung infection or something like that. And those are the group that had more cognitive impairment, interestingly, the moderately unwell people. Then there were severely and very severely unwell people. So in Wuhan, they followed a whole group of people for 12 months. And as you can see, people still had symptoms after 12 months. What's interesting is to have a look at the people who with shortness of breath. About 26% had shortness of breath at 6 months, but 30% had it at 12 months. So some people were getting it worse. 6-minute walk test was longer. Chest pain was a bit longer. I'll be pleased to tell you that hair loss got less. So that made me feel a lot better. Oops. Oh, goodness. Do you know how I can go back? Yeah, here we go. Previous, sorry. There we go. I did try to use the arrows. They misbehaved. Okay, so these are the common symptoms for long COVID. You can see fatigue is at the top. Ground glass opacification on your chest X-ray. So that's an organic thing that happens to a fair few people. Insomnia is a big issue. Difficulty walking, anxiety and depression. We found in our clinic that mental health is significantly part of the presentation. Partly because people have a good hold on their mental health when they're fit and doing all their usual things, and as soon as they're unfit, the mental health thing goes out of the window. There was memory problems and myalgias and things like that. So is it different to other illnesses characterised by fatigue? Because, this is a big worry. A lot of people who've had chronic fatigue syndrome are very angry about the intense amount of resources and research into long COVID, which was a disease brought on by a virus causing fatigue. When they had fatigue in the 80s and 90s, there wasn't such a great interest in them. So many people are annoyed about that, and we're learning actually from that population a little bit about the population that we have now. So the characteristics that make it different to any other illness is that shortness of breath is one of the main hallmarks. It's a respiratory virus. It goes into your chest. The second thing is there's X-ray features. That often is not the case in other viral illnesses. There's blood markers. The other thing is if you go to hospital, you get steroids, because steroids is the only thing that was found to work. And if you have steroids, you get all these complications from steroids. They can make you loopy, they can thin your bones, and they can give you diabetes. So some people have problems from the actual treatments. And then, of course, a lot of people got PTSD from being in hospital. I don't know if you know what proning is, but it's pretty awful. Apparently, if you lie on your front, your lung capacity improves by about 15% because the back parts of your lung are free to expand. So these people are really crook. They're coughing up huge amounts, and they're needing supplemental oxygen. And then the nurses and the orderlies turn them on their stomach for 8 hours a day, and they have to look through a hole in the bed to the bottom, and there's a little mirror so they can watch their TV show or something. So you can imagine how awful that would be. What if you have a bad back or something, and you've got to do that? So a lot of people got PTSD from that, and we know that 1 in 3 people who go to intensive care gets PTSD. And there were a wide variety of other symptoms, including this postural tachycardia, people who stood up and they suddenly got racing heart rates, and we couldn't really work that out. Now, we also noted in long COVID this thing called post-exertional malaise. So it's where when you do a bit of exercise, we all know that it makes you tired, but these people are like floored. They can't do a thing. They go and have a shower. They've got to lie down and have a sleep for half an hour. So we noticed that as well. The other coronaviruses, there's been 2 others. One is SARS and one is MERS. In SARS, we know that the fatigue lasted for 4 years. But it did go away, which is good. Women and those using steroids had a lot more fatigue and weakness, and that's sort of similar. There was lung diffusion abnormalities that lasted for 12 months, and that's similar to what we're seeing. MERS, which is another coronavirus, had lung changes for 12 months. So what are the rehab approaches? So all the long COVID clinics are a combination of respiratory medicine and rehab. And that's because some people just have cough, shortness of breath or wheeze, and they just need a respiratory physician, or they don't just need, they need a respiratory physician, and they need a respiratory rehabilitation program. But if you had a pulmonary plus, we call it, anything on top of your lungs, then you need a rehab physician and a rehab service. And I'm sure you're familiar with that. But there'll be people complaining of memory loss, information processing, poor concentration, anxiety, depression, pain, limb swelling. And what we're seeing in our pain clinic is mostly we're seeing a lot of young people who can't get back to work. So they're young and fit. Some of them are a bit, I'd call them, high achievers. They're type A's, they push themselves, and then they get this fatigue and they cannot tolerate it, and they can't work. And we had a lot of people have to sell their businesses, and a lot of people needing assistance from social services for childcare. So it's not nothing. This is developed. This is called the Yorkshire COVID-19 screening tool, and it's the only validated screening tool for COVID-19 developed by a rehab physician in the UK. It's available, New South Wales Health has it available online, and it's actually the only way you can keep an eye on whether people are improving or not at the moment, because we don't have any blood tests yet. Do you want me to finish up? Yeah, right. No. 5 minutes, okay. Managing long COVID in the community. So these are some of the things that we do in our clinic. The first thing to tell you is the GP is the first port of call. The second thing to tell you is that we look at cognitive testing, and we set up access to psychologists and physiotherapists, and we use health pathways to teach the GPs how to manage. Fatigue, for instance, we've written a program, a guide of how to manage it, and we've talked about what needs to be done for fatigue. You need to exclude depression and anxiety. We need to give a very tailored program of activity or movement, a very specialised program to individual people, because some people will go at it hammer and tongs and then crash, and some people need to be sort of paced. We give them behavioural problems and nutritional review. We'll often get the OT to be involved in return to work and driving. So who to refer to rehab? Patients with exclusively pulmonary symptoms need to go to pulmonary rehab service. If you've got anything more, then you need to come to a multidisciplinary rehab service. When the GP feels that they can't manage, when there are more than one therapist, and that's hard to coordinate in the community, and when and sometimes getting services in the community is expensive, so the public hospital is free, and that's a driver as well. We talked about the ADAPT study. I think I've run out of time to talk to you about that, but because of the ADAPT study, we've got two things now. We've got a marker for recovery, this quinolonic acid. We can actually do blood tests to see if it's dropping down or high. We don't know exactly what that means, but it looks like it goes down as you get along. So it will give us some idea, and it might be a treatment. Some of the recent research shows that certain issues are emerging, but we don't really know. People who report cognitive issues when they were tested, guess what? They had them. So, reporting them, some people say, everyone says they're losing their memory, but no, we found that. We know that with cognitive problems, you have a poor quality of life, so we know there's a reason to treat people. And we know that if your lung's worse, the D-dimer levels get worse and you've got a higher risk of clotting. And people over 50 in Wuhan, when they were compared to another group of people over 50 who just went to hospital, as opposed to those who went to hospital with COVID, had the same cognitive impairment. So the question is, maybe when bigger amounts of larger studies are done, we might find that it's part of the trauma response, post-traumatic trauma response, as opposed to a immune response. But at the moment, we're focusing on the immune system. I'll keep going. So for you people in the audience who are familiar with cognitive impairments, the treatment's pretty much the same. These are the standard assessment tools. So this is what the International Neuropsychology Task Force wants us to collect. And we use occupational therapists to look at how you can improve your functioning in the community and also how you can get back to work. So it's not magic what we're doing, we're just applying it to a new population. We've noted recovery in all of these areas, but for some people it persists. About a quarter of ICU patients had PTSD, what we're noticing in our clinic is that people are improving, but it's slow, 3 to 6 months, and they need to have a very careful, individualised program. We've written this sort of clinical indicators that's available on the New South Wales Health website, and we've talked about how to assess them, what the role of the OT and physio is. I won't go into that, you guys all know this. I just thought I'd talk about 2 case studies. I promise I'll finish, okay? So one is a guy with severe PTSD, severe traumatic brain injury, motor vehicle accident. He had carers at home, and I've been looking after him for many years, and he, highly distractible, great guy, did everything he was asked to do, but occasionally had difficulty sleeping and was up all night and often went down into rabbit holes, and wrote letters to people and things like that. Anyway, he got it bad, and he went to hospital, and 2 things happened to him. One of them is they wouldn't let him in ICU. Because he's old, they knew that if he was intubated, they wouldn't be able to get the tube out, and he had to have an advanced care directive. You imagine how complicated that would have been, right? He had 2 sons, they were his powers of attorney, and they were incredibly distraught, and he didn't have an acute care directive, so they didn't know what he wanted to do, and he couldn't really work it out at the time. He was so crook. So that was incredibly stressful, because we had to have discussions about if you die, where would you like to die, and all those sort of things. So you can imagine how difficult that would have been. The second thing is he was proned 12 hours a day. You can imagine, he flipped out. We had to use so much sedatives to control him when he was prone. Can you imagine how much PTSD he would have had? Anyway, he's had so much PTSD, or she's had so much PTSD that she's had a number of admissions, and it's really complicated to manage her now. The other one is a young man who works. He's had bad TBI, but he's able to work in a clerical capacity in a hospital, and he just started falling asleep on his computer. And they started to think he needed to be shifted off and lose his job. So when he came, we advocated for him. We got him onto a program. We told the workplace what the issues were, and he's still at work. and he's having a slow recovery. But you can see that for people with TBI, it's going to be not as straightforward. We've produced quite a few documents. I promise I'll finish up, Nick. And here they are. And they're all on the New South Wales website. And just want to remind you that in 2024, we will be running the International Rehab Congress in Sydney, and we formally would like to invite you all to attend. Thank you very much.
Please thank Bruce and Stephen.